Okay. Good morning, all dear faculties and dear colleagues. Am I visible and audible?
Yes, doctor. The slides are visible and your voice is audible.
Okay. So, I'm presenting my study in a clinical and angiographic profile of young patients of ischemic heart disease, a Central India study. So, I am thankful to my guide also, Dr. Vikas Bisne, for the help he has provided to me. We know the cardiovascular diseases, they are the leading cause of death globally, and around 17.9 million it claims lives per year. Many behavioral factors are known to occur, like unhealthy diet, physical inactivity, tobacco, and harmful use of the alcohol. What is the effect of this behavioral risk factor? It leads to hypertension, raised blood glucose, dyslipidemia, and obesity. What will occur after the reduction of all these risk factors of CVD? If you cessation of tobacco use, reduction in the salt intake, intake of more fresh fruits and vegetables, and the regular physical activity, and if you avoid harmful effects of alcohol, it definitely has an effect, as so many studies are there, which causes decrease in the prevalence of the coronary vascular disease. What is premature coronary artery disease? Is the disease occurring in an age less than 55 years in men and 65 years in women. We call it the severe or the malignant CAD when it occurs in the age less than 45 years. Especially the Indians, we are more prone for at very younger age. The 50% of the heart attacks occur before 55 years, and around 25% heart attacks occur before the age of 40. So that is a burden of the CAD in our part. These are the figures from 2013, when there is an increase about 7-fold in the urban areas, and it has quadrupled in the rural areas from 1.7% to 7.4%. The urban areas, definitely the diabetes mellitus also has doubled. Rural areas, still the smoking is a major risk factor. And there are so many differences in the hospital and the discharge medical care facilities. So CAD in young, especially, so many definitions are there, especially when it occurs less than 45 years of the age. Recent study indicates the prevalence of 1.2%. Ethnic wise, South East Asians, especially Indians, the prevalence is of course 5 to 10%. Most common risk factor is the smoking. Several genes have been attributed, like CETP, lipoprotein lipase gene, ApoA1, ApoE, and ApoB. Various biomarkers are associated with the premature CAD, like lipoprotein A, fibrinogen, D-dimer, gamma-glutaryl transferase, vitamin D, and osteocalcin. One important thing is, as the previous speaker described, there are many thrombotic lesions are more common, and that is why the prognosis is better with the thrombolysis and the early if arrival at the hospital. Poor prognosis, especially in obesity, and if the person is currently heavy smoker. What is angiographically findings are there? They are predominantly they are having single vessel disease. So they are the study by Agarwal et al. So this study I carried out to study, have the clinical, biochemical, and the angiographic profile of the ischemic heart disease in young adults, to study various traditional risk factors and certain newer risk factors like lipoprotein A, fibrinogen, and homocysteine. We also studied correlation of the significant and the non-significant coronary artery disease with various risk factors. It was a cross-sectional, it was a monocentric hospital-based study at Super Specialty Hospital Nagpur. I recruited total 70 cases during over a period of 2 years. Males less than 35 years of age, and females we studied less than or equal to 40 years, considering the reproductive age and the premenopausal age. Ischemic heart diagnosis was made by the guidelines by the ESC and the AHA. We studied them clinically, biochemically, and angiographically. The newer risk factors like lipoprotein, homocysteine, and fibrinogen was studied in 44 cases only due to some constraints, and appropriate statistical analysis was done. So this is a chart table showing our age distribution. I can show here the majority of the subjects, they were in the age group of 31. Majority of the subjects were the age group of 31 to 35 years. And in the female group, which was there, they were in the age group of 36 to 40 years of age. That is 9 cases, so 12 to 12.8%. The average age of presentation was 32.97 plus minus 3.93. Regarding gender, there are majority of the cases, 84.28% were males, while 15.7 were females. Again, it corresponds to the various studies by various authors. As occupation was studied, majority of the subjects were in the businessmen. They were physically active, around 54.28 were there, and other categories include laborer, farmer, then drivers. Only one student was there. The youngest patient in our study was 21 years of age, and he had a normal coronary angiography. Again, this is showing so highest class belonging to the business class of group. The associated factors like stress was studied. Of course, the stress is a very difficult to study. We cannot quantitate the stress, but we have got only suprarenal mass was there in one case, that is 1.4%. Then job stress was there in 1.4%, and cerebrovascular episode presented in 2.8% of the cases. Various conventional risk factors were studied. In our study, smoking, diabetes mellitus, hypertension, tobacco, that is a gutka chewing, was the important factor that we found out. So this is a gutka that we get over the counter. It is a form of tobacco, and people eat it like various classes. They eat this gutka, and it is found to be about 35.71%. History of premature CAD was present in 8.57%. So important factor found out to be a gutka chewing or the tobacco. It is a smokeless tobacco in 35.71%. So again, you can see that tobacco has a important association with our CAD patients. So our study correspond to the other authors like Hari Krishnan, Bharadwaj. They also found out smoking as an important traditional risk factor. Center to value found out 43.75% of the cases having diabetes mellitus, while again Kasliwal in their study found systemic hypertension to be 70% of the cases. While our study, we find tobacco chewing is an important factor in 37.71%. Another type of myocardial infarction was studied. The majority of the group, about 74.6%, they presented with the anterior MI, followed by the inferior MI and NSTMI and unstable angina. So anterior MI was the predominant presentation in our group. LV function in these patients we studied, majority of 61% patient presented with moderate LV dysfunction. So metabolic syndrome was studied. It was absent in about 87.15% of the patients. And this is very contrast to the elderly population, which are mostly obese. Our population was not very obese, and they were active, physically active. So the traditional risk factor, lipid profile was studied, and the decreased HDL was found to be 61.85% of the cases, followed by about increased total cholesterol and increased LDL and increased triglycerides. So our study, again, we compare with the other groups. So Hari Krishnan et al. Found dyslipidemia in 92% of the cases. Bharadwaj et al., they found decreased HDL in 43.1% of the cases. Kasliwal, they found out decreased HDL in about 72.5% of the cases. In our study, we found decreased HDL in about 62.85% of the cases. So newer biomarkers were studied, like lipoprotein. The average value was 47.18 milligram per deciliter. Homocysteine was studied. It was found to be 29.78 millimole per liter, and plasma fibrinogen was 333.25 milligram per deciliter with standard deviation. The coronary angiography was done in all the subjects. We found predominance of the single vessel disease in 57.14% of the cases, followed by DVD, double vessel disease in 11.47%, and TVD in 7.14% of the cases. The angiography was normal in 24.28% of the cases. So predominance of the single vessel disease was found in our study, which also corresponds to the studies by other authors in a young CAD patient. We found out thrombus in 4.2% of the cases and dissection in 4.2% of the cases. This is the echo of one of the cases having LV apical thrombus, young patient. So, depending on the coronary angiography involvement of the vessels, the predominant Bharadwaj et al. Found out single vessel LAD involvement in 86.1%. Sengotu value found out LAD in 59.4% of the cases. In our study also, we found out LAD involvement predominantly in 82.5% of the cases. Another author reported 6.2% of the aneurysm, and we found out dissection in about 4.2% of the cases. And study by Deshmukh et al., they found out dissection of the arteries in 4.87. So predominantly LAD involvement was seen in most of the studies. So this is one of the angiogram of the patient who was a young patient of 33 years old, and he had a triple vessel disease. So you can see the severe critical stenosis of the LAD and LCX. The RCA is not seen in this. This is another patient, having young patient of 28 years old, showing the coronary artery dissection in the RCA. Another patient having severe LAD stenosis, 90%, she is just 29 years of old. This is important siblings, brother and the sister. We showed of course, the one admitted after the first, that is brother, after about 3 months, and we can see total cutoff of the LAD in the female patient, while in the male sibling, we find the LAD, of course, the critically narrowed LAD. So both the patients, they were having history of premature CAD in their family. So I am presenting case 1 here. She was a young female, and she has angina for 1 month. When she was admitted, she has anti-wall MI, and she was 32 years at that time. She was hypothyroid. There was no history of premature CAD. She was on insulin and OHA. And after that, when she presented to us, she has biochemical profile of total cholesterol 130 milligram, total triglycerides to 15 milligram %. HDL was 39.2 milligram %, and the ratio of TC and HDL was 3.31. So this patient has LAD involvement on angiography. Of course, about 80% of stenosis in the proximal LAD. She was treated with angioplasty. And after angioplasty, she has got good results. So she was treated with this Pronova stent, and she has a good result with a good flow. So TIMI-3 flow was there in LAD. So second case was 27 years. He presented in 2007 with anginal pain. There is no history of diabetes or premature CAD. He was a tobacco chewer for 4 years, unmarried. TMT was negative, and this patient was also on the regular treatment. He was again admitted in 2013 for palpitation. So during his index admission, these were the parameters. Fasting blood glucose was 100. Total cholesterol was 186 milligram %. The HDL was 40 milligram %, and the ratio of TC and HDL was 4.65 milligram the ratio was 4.65, and his LDL was 132 milligram %. So this patient has again critical LAD stenosis, and he was also underwent angioplasty with the Pronova stent, and these are the result. After this stunted, the good flow was there. His RCA was normal. So again, in both of the patients, the LAD was critically involved. So you can see the flow in this patient after the angioplasty. There was a good flow. So we studied the risk factors in other normal CAG. In those patients, the CAG was normal. The tobacco was found to be predominantly in out of 17 patients, 8 patients. It is more than 50%. They had the tobacco, smokeless tobacco as a important risk factor, followed by smoking, hypertension, diabetes. So these are the finding in those having normal coronary angiography. After that, we studied the clinical characteristics, compared the group, those having significant coronary artery disease and non-significant coronary artery disease. So in this age group, we had different like smoking and other risk factors we have studied. Premature history of CAD was found to be statistically significant in the group having significant CAD and the non-significant CAD. Significant CAD, we had taken the coronary stenosis more than 70%. The other factors like smoking, diabetes, hypertension, and the gutka were not found to be statistically significant in this age group. The other lab characteristic we studied in the significant CAD and non-significant CAD, again in these triglycerides, then the ratio of total cholesterol and the HDL, and the LDL and the HDL. These three parameters were again found to be statistically significant in these two groups of significant CAD and the non-significant CAD. Other newer risk factors were studied in the two age groups, groups like significant CAD and non-significant CAD, but all the like three factors like fibrinogen, homocysteine, and lipoprotein A were not found to be statistically significant. We again studied involvement of the proximal or the mid-LAD and the non-LAD region. So comparison of the LAD and the non-LAD region. Here we found out family history of premature CAD, it was found to be statistically significant. While again tobacco intake, smokeless tobacco also found to be statistically significant in the two age groups, while having those having proximal or the mid-LAD involvement and the non-LAD lesion. We compared the biochemical parameter in the two groups. Again, here we found out ratio of LDL and the HDL to be very significant, those having proximal LAD and the non-LAD lesion. The newer risk factors which were studied in the group like left main or the proximal LAD stenosis and non-LAD lesion, but none of the factors like fibrinogen or homocysteine or lipoprotein A was found to be statistically significant in the according to the type of lesion involvement. So my study concluded with, we have got a average age of the patient was 32.97 years plus minus 3.93. Male patient predominated in the study 84.28%. The female, again, they were 15.7% involvement was there, and all females were in the age group of 36 to 40 years of age. The female were mostly found to be diabetic in this subgroup. So male patients were predominantly 31 to 35 age group. So major conventional risk factors like tobacco was seen in 35.71%, hypertension in 22.84%, smoking in a 17.1%, diabetes mellitus was least common of the like 11.47. The history of premature CAD was seen in 8.57%. As compared to the other study, we also found anterior MI to be a common presentation in 74.6% of the cases. Females, again, anterior MI was more common. 36.36% were diabetic in a female group. Metabolic syndrome was only present in 12.85%. We found out elevated total cholesterol in 38.57. Important finding is a decreased HDL in 62.85%. The newer risk factors, increased lipoprotein A seen in 61.36%, increased homocysteine in 77.27%, and increased fibrinogen in 18.18%. Single vessel disease was found predominantly 57.14% of the cases. Normal coronary angiogram seen in 24.28%, and of this normal angiogram, 46.07% at the habit of smokeless tobacco consumption. LAD was the most culprit vessel in 82% of the cases. LMCA, left main coronary artery involvement, was not seen in our case. In few studies, they have also found to be a involvement with the LMCA. So significant CAD was associated with the positive history of premature CAD, increased serum triglyceride, total cholesterol and the HDL ratio, and the LDL and the HDL ratio. So these four parameters were associated with the significant coronary artery disease in young subjects. Then LAD lesion association with the positive family history of premature CAD, tobacco intake, and the LDL and the HDL ratio. So LED lesion, like proximal LED lesion and the mid LED lesion, was mostly associated with the positive family history, tobacco intake, and the LDL and the age related. There was no correlation was found between significant CAD and LED lesion with a newer risk factors. The other investigator like Pineda et al., they also studied lipoprotein A, they studied fibrinogen, and the Pineda et al. Found again the fibrinogen to be an important risk factor associated with the coronary artery disease in a young patient. While Vishwanath Mohan also from the southeast like India, they found to be also associated with risk factor as a lipoprotein A also. So, but in our study, we could not found the newer risk marker association with the coronary artery disease in young subjects. So, our limitation, it was a single-centric study, cross-sectional, no controls were taken, and some patients were already on statins, they came late to us, and newer risk markers we could study only in 44 subjects. So, take-home message, Southeast Asian, the males in Southeast Asia, they are more prone for the coronary artery disease, especially less than 40 years of age. Early screening for risk factors should be started early. The tobacco consumption in the form of gutka especially should be discouraged, and the healthy dietary habits in the form of fresh fruit, vegetables, and the fresh vegetables should be encouraged. So with these remarks, I conclude my presentation. I am thankful to you and thank the organizer for allowing me presentation in this Heart 22 conference. Thank you.
Thank you.
Thank you,
Professor Kumbhalkar, for this presentation, for an excellent presentation. I hope we have benefited and learned immensely from our presentation. Do you have any questions for